The first talk is on ocular surface squamous neoplasias, and the common question that many of us have and which many of us ask is whether to excise or use topical therapy and what's the best for a tumor that presents to you. So I have no financial disclosures to make, and yeah. So I realize that you do something better if you know why you're doing it. So if you know why you would like to hear to this talk, maybe you can carry home the message better, and that's why I thought this should be the first slide. So ocular surface squamous neoplasia is the most common ocular surface malignancy, with an incidence that's been reported of around 1 in 1 lakh population. But India is in a zone which has high solar radiation exposure. So if you are practicing in India, or for that matter, any other area close to the tropic, then you are more than likely to come across a lot of these patients with ocular surface squamous neoplasia. And it is then that one would wonder, what is the best way to treat these patients? So before I go on and answer that question in today's scenario, I would like you to understand that ocular surface squamous neoplasia, despite being a cancer, is not one of the cancers where you think of fertility or death. It is a tumor which is characterized by high morbidity, and the morbidity is related to recurrence. So you could see recurrences in as high as 56% of cases, which could go on and cause intraocular invasion, or maybe an orbital invasion requiring exenteration. So much so that it is now one of the most common causes of exenteration. Metastasis, if you see, it occurs in less than 8% of cases, and death would be in less than 5% cases. So mortality remains the main cause of concern, which could be in terms of corneal opacity, in terms of intraocular extension requiring enucleation, corneal melting, or even exenteration, which is extremely disfiguring. So what are the treatment options? Of course, you want to treat the patient with something that would reduce the recurrence rate in these patients, thus reducing the morbidity. So you could do surgical excision, which still remains the standard of care, and then you have topical treatment. So we know that surgical technique is quite well defined for ocular surface squamous tumors. It has to be a wide local excision with no touch technique, because we don't want to touch the tumor. If you touch the tumor and manipulate it, it will cause seeding of the surrounding conjunctiva, bringing about recurrences. Also, you would want to do an alcohol-assisted epithelialectomy of the involved corneal epithelium and a reverse double freeze thaw cryo of the conjunctival margins. That is that. But surgical excision can have high recurrences, especially if the surgical margins are positive. And also, you may not be very comfortable doing surgery in large or extensive tumors. And that brings us to why topical treatment is so attractive and has become so popular. So though surgery remains the gold standard of treatment, there are advantages of topical treatment, including painless. It's painless and minimally invasive, treats the entire ocular surface, even the hidden or missed areas. And surgery is, of course, difficult in cases like this, or maybe even this, where you cannot see the margins of the tumor. But that doesn't mean you go in and use topical treatment in all the cases. So you must know where not to use topical therapy. So you do not use topical therapy if you have invasion of the ocular coats. How to assess that? You could do a clinical mobility, or you could do UBM or OCT. So this is the UBM of a case where there's no scleral invasion. This is another case, and you can see scleral thinning and possibly invasion. Another one with corneal stromal invasion. But then there are also other high-risk features you must keep in mind. So if there's history of previous surgery, morphology which is nodulo-ulcerative or endophytic, or a mucoepidermoid histology, go in for surgery and not topical therapy. So when should you use topical treatment? When surgery is likely to have significant side effects, larger tumors, like this, or maybe like this, but they should not have ocular coat invasion. Where patient has a smaller tumor but is unfit for surgery, or as adjuvant treatment where margins are positive or unassessed. What are the choices? You have chemotherapy, and immunotherapy. So chemotherapy is what is still being very popularly used in our country and maybe the world over as well. That's because it is cheaper, it has shorter duration of action, and it can be stored at room temperature. But most importantly, what is making immunotherapy more popular? Greater side effects of chemotherapy. Mitomycin C is the most common agent that's used, and it has side effects. It can cause limbal stem cell deficiency. It can cause lacrimal punctal stenosis. This patient we treated with MMC, and after that, he developed a stenosis and watering. And if the patient uses it without you telling him to do so for years on, you can have scleral corneal melt. So now, immunotherapy is actually replacing mitomycin C as the first line. What is it? It's a cytokine, interferon alpha-2b that is used. It comes as an injection, needs to be reconstituted to drops. You can use it as 1 million international units per ml or as subconjunctival injections. We use it as first line at a center, and many centers do in the world. Now, how to decide between topical versus perilesional therapy? So what you need to remember is, if you want to give topical interferon, you need to have cold storage, and perilesional interferons produce systemic flu-like side effects. So if you have a doubtful compliance issue, or the cold storage is problematic, or you're aiming at a faster response, it's better to use perilesional therapy. If the compliance is assured, cold storage is not an issue, and perilesional is not feasible, like in this case, topical is a better choice. This is a short video on the technique. I think I'll skip that, otherwise I'll run out of time. If I have time, I'll show it in the end. The protocol that we follow for eye drops is, you start the eye drops and reassess after 6 weeks. If there's a decrease in size, continue, reassess every 4 weeks till it regresses, or till complete regression, and continue for 1 month. For injections, we reassess after 2 injections, and injections are given at 2 weekly intervals. And thereafter, you reassess after 2 weeks and continue till complete regression. It is important to remember that you have to give a maintenance therapy of 1 to 2 months of topical treatment after complete regression of tumors. This has been our experience with use of interferons. I will just run through the slides. We have seen extensive tumors just melt away with this drug when it works, and even the ones which are very, very large and diffuse involving the limbus. But then there are other smaller ones which have not responded, but they do, then as second line we use MMC, and then they disappear too. Some of them do not respond, like in this case, where they get immunoreduced, and thereafter we have excised and managed to save the eye in this case. We did a study on the cases that we have treated, and we found that almost 66% of our cases had complete regression that were treated with conservative treatment, and 92% showed some response. So to conclude, upfront surgery should be done for smaller tumors, that are tumors less than 3 clock hours, or limbal involvement less than 5 millimeters, tumors with scleral or corneal stromal invasion. Topical treatment should be restricted to larger tumors without scleral or corneal stromal invasion, with immunotherapy as the first line. Whether perilesional or topical has to be decided on case-to-case basis. MMC can be used as second line, and of course it can be used as adjuvant treatment after surgical excision. Thank you so much. I think we'll take the questions